Hi there, everyone. Welcome to Project Echo Care of Older Adults. My name is Pam Yankeelove, and I'm the Director of Research at the University of Louisville Traeger Institute Optimal Aging Clinic. And we do our Project Echo in partnership with the Kentucky Coalition for Healthy Communities. And we're glad you're here today. For engagement purposes, we do ask if you can go on and turn on your video. And we do ask that you go on and mute yourself. If you want to share a comment or you have a question, you're welcome to raise your hand or use chat or unmute. If you're having some difficulty with sound, you can go on and click on the arrow to the right and you can check your microphone and your video system. But if you get disconnected, you can always join us by phone, and the phone number is on the agenda. We do ask that you add your name and your organization to your video square. A couple of ways of doing that. You can go on and click on your little video square. There's three little dots in the upper right-hand corner. Click on that. A little dialog box comes down, says rename, and you can go on and put your name, your organization. You can also put your pronouns in there. Or what you can do is you can go to participants, which is in the lower portion of your screen, and you can rename yourself that way by finding your name in the actual participant list. If you're unfamiliar with the University of Louisville Traeger Institute Optimal Aging Clinic, our mission is about to help individuals optimally age throughout their lifespan. We're trying to help people expand their health span. We are a workforce development hub, so we have several grants, federal grants, state grants, in which we're really trying to help people work in interdisciplinary teams to help people optimally age. So this would be both individuals that are in their programs as well as seasoned professionals working together, all different disciplines that we have, whether it's medicine, nursing, social work, OT, PT, law, payers, just everyone across the lifespan or across the in the health space. Individuals from area agencies on aging. We also have a lot of those folks. So in addition to doing our workforce development, we also engage in practice transformation. We are trying to help our different clinical practices, whether they're nursing homes or emergency departments or outpatient clinics, to be more aware of how to be age-friendly and trauma-informed using the four M's. And we also engage in community transformation because as much as we spend a lot of time with our healthcare team, there's a lot of our health that goes on in the community. So we all really try to work on all concentric circles around that individual and their family and their caregiver to kind of help transform their health experience. And we do this particular Project Echo in collaboration with the Kentucky Coalition for Healthy Communities. And I believe Justin is going to share the mission.
Yeah, thank you, Pam. So the Kentucky Coalition for Healthy Communities aims to create community support systems for older adults in partnership with existing local coalitions and organizations, and work to develop the workforce and concerned community members to empower our communities to become healthier.
So you may have heard me talk about lifestyle medicine. We are driven here at the Traeger Institute by the 6 pillars of lifestyle medicine, trying to help folks think about how it is that food is medicine and activity, physical activity and mobility is medicine, that restorative sleep is medicine, avoiding risky substances is medicine, as well as social connection and stress management. And those are the pillars that are put out by the American College of Lifestyle Medicine. We're also driven by the 4Ms framework. The 4Ms is age-friendly healthcare. It was developed by the Institute for Healthcare Improvement and the John A. Hartford Foundation. And healthcare systems really try to focus on, when they're working with older adults, to focus on the 4Ms, what matters most, making sure we're always looking at health through the eyes of what matters most of the actual individual, making sure that the medications that an individual is on doesn't affect what matters most, and that we reduce any risky substances or prescribe, that individuals have daily mobility goals that they want to go on and achieve, and that we're always looking at mentation, which is the mind and the mood, and then we're making those assessments and making sure that those are part of our health plans. So here is our winter schedule slash false spring is what I think we were joking about earlier schedule. And we are here to talk about suicide in later life, recognizing risk and responding with compassion. In April, we're going to be talking about gardening for health, a great topic also to be able to incorporate in April, talking about movement and nutrition and connection to nature. May, we're going to be talking about pulling back the sheets on older adult sexuality. In June, we're going to be talking about nutrition and social connection, the power of shared meals. And in July, we're going to be talking about comprehensive management of complex voiding dysfunction. So if you have your iPhone, you can go on and click on this, or if you go on and schedule through iEcho, you will have access to all of these as part of being part of the iEcho platform. So if you're unfamiliar with Project Echo, Project Echoes actually happen all around the world. They were started in 2003. It is a telementoring platform. The idea is to move knowledge, not patience, and try to build capacity at a local level. Dr. Sanjeev Arora is a hepatitis C expert, and the reason why he started this particular platform was because he said that patients were driving 200, 300 miles to come and get his expertise, and he said he wasn't creating greater capacity to see a higher volume of patients. He was just taking one patient away from one particular spot on a schedule away to another individual. So he thought about this telementoring platform, about how we can move the knowledge, and so in Project Echoes, there's case-based learning, there's usually a didactic, then there's some cases we talk about, and then it's a teach-all, learn-all environment in which we are working together in interdisciplinary teams to develop recommendations and learn from one another. If you're interested in receiving an attendance certificate, attendees can receive a certificate for 1.5 hours for today's session. We just ask that you go on and complete the evaluation at the end of the session to let us know that you're interested in the certificate. And if you are a certified community health worker and a social worker, you must go on and complete the evaluation to receive the continuing education units. So the Kentucky Office of Community Health Workers provides 1.5 CEUs for certified community health workers, and Brescia University is providing CEUs for our social workers approved by the Kentucky Board of Social Work. So our didactic presentation today is by Dr. Karen Wyatt, and the presentation is Suicide in Later Life, Recognizing Risk and Responding with Compassion. So let me share a little bit about Dr. Wyatt with you. Dr. Wyatt is the best-selling author of the book 7 Lessons for Living from the Dying, which contains stories of patients she cared for as a hospice doctor and the spiritual lessons she learned from them at the end of their lives. Her books include The Journey from Ego to Soul, Stories from the Dark Night, and The Tao of Death. Dr. Wyatt also hosts End of Life University podcast, which features conversations with experts who work in all aspects of end-of-life care. She is widely regarded as a thought leader in the effort to transform the way we care for our dying in the United States. In addition, she is valued for her application of spiritual principles to illness and health care, and teaches that in order to live life fully, we must each overcome our fear of death and embrace the difficulties that life brings us. Thank you, Dr. Wyatt. So you are ready whenever we're ready, whenever you're ready.
All right, thank you so much, Pamela. I'm honored to have a chance to be here and talk to you, and also really excited to see the topics that you're covering, which are also very important, including, as you'll see when we talk about suicide, many of the things that you're focusing on are actually the very things that would help reduce the risk of suicide for older people. So I love what you're doing. And I'll start by talking about on the next slide about why this subject matters, because suicide is actually a significant cause of death in our society, and you'll see for older people as well here in the US. But it is also something that we have a hard time talking about. And as someone, I've been talking about it for most of my career because my own father died by suicide many, many years ago when he was 69 years old. So it's been a part of my life, my whole adult life, to be trying to understand suicide, why my father made that choice, and also how to live with the grief after a suicide death. But I talk about it openly and often with people because it is still a taboo subject and stigmatized in our society, and people are afraid of it. And I will say, oftentimes when I'm the scheduled speaker to talk about suicide, I find the audience is small, smaller than expected, because it's so hard sometimes to even show up and hear someone else talk about it. But I keep talking, and the talks are recorded, and anyone who's not here will have a chance to hear it later. So I hope that you find it beneficial for you. For me, being able to talk openly about this information is a way of honoring my father and also finding meaning in his death and in the grieving process that I've lived through for years. So let's talk a little bit in the next slide about the fact that older adults are at the highest risk of anyone in our society. Adults 85 and up have the highest suicide rates of any age group. And that feels very sad to me because when people have lived a long life and gathered a lot of wisdom about life, to know that they feel hopeless in some ways or feel that there's nothing they can contribute is really a tragedy. And because you're a group that works with older people, it is so important that you're aware of and sensitive to the issues that could push someone at an older age toward suicide. As you can see, the rates go up significantly after age 75. And in the next slide, we see older men are at the greatest risk. 80% of suicide deaths occur in men. I was a little shocked to read that at first, but the rates are quite high for men over 75 and especially over 85 years of age. And some of the reasons, or let me, next slide, why the older adults are vulnerable. Common risk factors, loneliness and social isolation is, I put that first because that is actually one of the risk factors that all of us can do something about by being aware of it. And I noticed that you've already had a talk about social connectedness, and that's part of your platform. And it's just so very important as our society gets more and more fragmented and separated. I think it's easy to overlook some of the elders in our lives or around us in our neighborhoods or our apartment buildings who may feel left out and forgotten. And it's something that we can all do something about just by being more aware of the importance of paying attention to loneliness. And so another risk factor, the loss of spouse or friends, is uh, especially difficult, I think, for men because many men have relied on their partners as the emotional aspect of their lives. And when they lose a partner, they may not have other emotional connections, close connections with other people around them to fill in that gap. Clearly, many older people are dealing with chronic illness and pain, something else that we can attend to with all the 6 types of medicine that you're talking about, that we can actually improve the quality of life and diminish some of the symptoms that people are experiencing with in later life. Depression, as it points out here, often gets underdiagnosed in older people. We may not think to ask if they could be clinically depressed because we kind of get used to older people slowing down or not talking as much or seeming withdrawn and feeling like that might be something normal. And it's important to keep in mind to always look for signs of depression. And then a loss of independence, a loss of purpose in life. Part of the aging process is learning how to cope with things changing and really falling apart and becoming different in life. But our society hasn't really prepared us very well. Our society emphasizes being independent, being an individual, having your own purpose in life. And so many of us don't learn tools that could help us when we get older and things start changing in how we function in the world. And so the next slide just emphasizes that As far as loneliness and social isolation, nearly 1/3 of older adults report feeling lonely. That's a huge number. And it's just so important that we pay attention to that and remember the value of connecting with people, and even small connections make a huge difference. But in the work that all of you are doing, you are creating connections with people. And I think remembering anything we can do to foster more connections and to even talk with older people about loneliness and sponsor programs that help deal with loneliness and that provide more avenues for social connectedness for older people. I think that's extremely important. And this, I was really impressed. An article came out with this very title. I think it was a couple of years ago. Loneliness can be as harmful to health as smoking 15 cigarettes a day. And while all of medicine has reacted to cigarette smoking as being bad for your health and can talk about that easily, we've really overlooked loneliness as a significant cause of harm to our health. And now I think is the first time we've really been bringing that up as an issue and we're looking at it. So I wanted to emphasize that. There are some warning signs to think about when you're working with an older person to watch for. First of all, talking about wanting to die. I do hear older people sometimes joking about, getting ready for the Grim Reaper or ready to kick the bucket. Sometimes it can be a coping mechanism in a way to have humor. But if someone is seriously saying things like, I don't want to be here anymore, or there isn't a reason for me to be here anymore, or I wonder why, we have to listen to that and take that very seriously. And again, if we see someone withdrawing or intentionally isolating themselves, and I think that's challenging because, as I said before, sometimes it appears normal to us that an older person is less active. They go out less often, they participate in events less often. But there's a difference when someone is withdrawing in a painful way because they no longer feel that they belong here or fit in, or when they're just slowing down because they like to rest more, because they have new interests or new hobbies that require them to stay home more or be a little bit more introspective or on their own more. So it's important that we think about, is this person seeming isolated because it's their choice and because that's what they need and they're enjoying that right now? Or is this an isolation that is causing them harm? And then the next sign is when people start giving away belongings, which again, that's mixed because sometimes that's actually a sign of, letting go and wanting to simplify lifestyle and decluttering and being ready to give things away. But there could be a way of when someone is actually clearing things out because they are intending that they won't need those things anymore in the very near future. So it's just important to understand if someone starts wanting to give away their belongings, asking, well, why? Why are you choosing that? What's going on? Um, when people express a lack of hope for the future or feeling like they are a burden, that is another sign that they're starting to weigh the value of their own life and wondering if being here is too much for other people, if it's asking too much of the people who support them for them to still be here. And they may be wondering if everyone would be better off if they were to leave. Again, it's a really good topic of conversation to have with an older person and ask them what they feel about their place in this life, what they've learned, what they feel the meaning in life is for them. Sometimes they can't see the meaning. They're not aware of what they're offering to others. Sometimes they just need to be told, but you share stories with me that have helped me grow. You've taught me things. I've learned from you. And to remind them that they have value and they're contributing so much still to our society. And we just need to remember it and be able to take the time to have those conversations. Another warning sign would be if we were to see an older person increasing substance use for one reason or another, as paying attention if we see signs of that and asking about it. Why is that? What is causing this? What is leading to this increased use of substances? And so one of the initiatives that I have found helpful, it's the Be the One To initiative that was started by some researchers at Harvard University, which their goal was to create ways that anyone can help. You don't have to be a mental health professional. You don't have to have any kind of training whatsoever. These are 5 things you can do that can help prevent a suicide. And the first is you have to be aware of the possibility and you have to be looking for it and looking for those warning signs. But the first way that the first thing that can help is simply to ask directly. And and we'll go through each one of these in subsequent slides, but I'll just list them now. Ask directly about what are you thinking? How are you feeling? Be there for them and perhaps stay with them if needed in order to, number 3, keep them safe for a while. If it seems that they're in danger, help them connect with resources, but also connect socially with other people, and then follow up with them after your encounter to see how they're doing. And because you're also creating continuity for them, there's someone there who actually cares about me, who actually knows what I'm thinking, who wants me to be safe, and who cares that I'm still here. So we'll go through each one of these 5 things in the next slide. The first one, asking directly and spending plenty of time listening. Come right out and say, have you had any thoughts about suicide? Are you thinking at all of harming yourself or of wanting to end your own life? And the reason we ask directly is because sometimes if we use euphemisms or try to hedge around it, we may miss the point and they may not get what we're really asking if we are not direct. And sometimes by coming right out and saying what we wonder, it breaks down some of the stigma, I guess, against talking about it and might allow them to answer us and talk to us about it. And in one of the case studies, we'll talk a little bit about how that can play out. But asking people about their pain, well, what is hurting you? How are you hurting right now? And do you have ideas for anything I could do to help you right now? Is there something you need in this moment that I could do to help you? So, number one, asking and then listening. And sometimes we need to listen to the stories that they want to tell us of what led them to the point they are right now. And that listening is one of the most important connections we can make for people too, because we're showing them their value, that we're willing to give them our time by being there and listening and hearing what their concerns are and what they're feeling right now. And in the next slide, the next be there. And of course, just our presence is reducing their isolation and loneliness for the moment. So being physically present, being willing to listen, being willing to even stay there with them a little bit longer if we need to. Um, Perhaps arranging to connect with them by telephone, like I will call you tomorrow. Let's talk later today. If we need to leave and we can't stay with that person, or creating a plan for connecting to others, finding out if there's someone else in their lives that you could connect them with, who could come and be with them for a few hours or check in on them, so that that when you leave, you're not leaving them totally alone without any type of connection. So whether you find another person who will fill in, and hopefully everyone has someone in their lives that could be reached out to connect for them, or that you offer, I'm going to call you when I get home later this afternoon, so that they can look forward to that phone call coming. And then, of course, follow through with the call that you've made. And the next step is to keep them safe in the moment. You do need to ask if they say, yes, I have plans, I would like to die. You ask, do you have a specific plan? excuse me, have you thought through a plan for how you would do this that tells you how far along they are on this trajectory of thinking about suicide? Because if they are so far that they know how they would do it, they've already thought of when they would do it and where, that tells you they're quite serious and they've been thinking about it for a while. They've been planning it out. And you might need a more drastic intervention at that point because they're very close to the actual act of doing it if they have made the plans. Um, you need to know if they have access to the means they plan to use. Do they have firearms in the home? Do they have lethal medications available to them that they could use? Um, Firearms are actually one of the most common ways that men choose to die by suicide. And so we do need to ask about it in our society. Lots and lots of people have access to firearms and know how to use them. And so it's an important question and something that it's helpful for us to know. As much as possible, reduce access to lethal means. That runs into a lot of ethical concerns and gray areas. But if you find out that someone is actively suicidal and they have firearms in the home, it's important to have a discussion and maybe bring in a family member to say, is it possible to remove these temporarily while we do some work to help this person? So we're taking away the means by which they would impulsively, in a moment, end their lives, to buy them a little bit more time so that we can work through some of the issues that are pushing them to this point. And I say this because my own father chose to use a firearm when he died. And so I see the fact that firearms allow people to act quickly, impulsively, but also lethally in the moment. And that's why they're so very, very dangerous. And in some cases, it might be if someone tells you, I'm going to do it today or tomorrow or urgently, and they have very concrete plans that we need to seek emergency care. We need to ask them to go with us to see someone else. We need to find a way to get them into for mental health help if they are at that point where taking action seems imminent for that person. And hopefully, with the people we're interacting with, because we're going to be having conversations, we're going to be working on isolation and loneliness, we won't have very many people who actually get to that point where an emergency intervention would be necessary. And that's the idea of this plan, in a way, is to start the conversation early on when we can identify things like loneliness or pain or depression and do something about it earlier on before they're at this end stage point in their planning. And then the next step is to help them connect. Uh, Make sure everyone knows about the 988 lifeline for suicide, which they can call at any time, 24/7, someone available to talk to. Um, it's safe. They can private. They'll have someone they can talk to about what's happening for them, what they're feeling, and receive some help there. Also know what resources are there within your community, because there may also be hotlines or organizations that you can connect people with, perhaps some volunteer organizations that could provide some connectedness for people who are lonely. Help the person create a safety plan. And it might be that you help them figure out how they can have at least one interaction every day with another person. And maybe you say, Tuesday, you'll call your daughter. Wednesday, we're going to have a volunteer come and visit with you. Thursday, we'll do this. It's maybe you help them create a plan, which also allows them to see into the future in a more positive way. Like, oh, there is a way that I won't feel this loneliness and feel so isolated in the future. And with the person, help them create a list of individuals to contact. It could be that you might need the list to contact someone to notify them on their behalf, but you're reminding this person that they have more connections than they realize. There are more people out there who care about them than they think. And as you create this list together, you remind them of neighbors, of people in the community, of maybe a faith community they belong to or another organization, that they know many people, many more than they're thinking of. And also, they know people who care about them, who would be willing to give them a phone call or show up for them every now and then. So sometimes people need help in order to see that. They can't quite see what's out there for them and available. And then on the last slide, following up, and that I mentioned before, if you say you'll call, call, leave messages for them, send text messages, a little, if they have a smartphone and you could text them once a day, that could be life-saving for someone to receive a text and just know there's a person out there thinking of me who cares what happens to me. And so, again, not all of us are in a situation where that's even feasible or possible. But what we might do is help put in place a little system of support around the person. Ask a couple of friends, could you send a text in the morning when this person is first waking up? Or could you give them a phone call in the evening before they're ready to go to bed? Just to say, hey, I just wanted to say hi and find out how your day has been. So you might be able to help them create a support network of people who would do this following up and connect with them. And I really like this. I like these 5 ideas of things to do. And I think it gives us a tool we can have in mind if we encounter someone and it becomes clear to us there's someone who's thinking about ending their lives. So the next slide. So I wanted to remind you again of the 988 Suicide and Crisis Lifeline, available 24/7 anywhere in the country. And they've made it simple now, just 3 numbers, 988. And there is also the Institute on Aging Friendship Line, which I just recently learned about, for individuals 60 years or older. Again, it's available 24/7, and it's kind of a conversation line. It's a listening ear where people can call in, talk about their loneliness, whatever it is that they need. But it's available 24/7. I love it's available for caregivers too, another group that's often isolated and lonely and needs support. And so this is a great number to keep on hand that you could share with people that they could call in the future. Um, if you are seeing older people, have in mind uh, a plan of action, I guess, if you found someone who was acutely suicidal in the moment, um, where, what would you do next? Who would you call? Where would you take them? There is usually adult protective services in the community that you could connect with, but is there a primary care clinic or a mental health clinic that you could utilize in the moment if you need it as a resource in your community? And so the next slide, I just wanted to cover some of the myths about suicide, which we might hear from other people. Myth that older adults who talk about suicide are just seeking attention. We can't overlook anyone who ever talks about wanting to end their lives, and we need to view it as a direct signal of distress and take it seriously. And we might find out once again it's just a joke or a passing thought, but we always have to take it seriously. The myth that depression is a normal part of aging, it's not actually normal in aging. It may be somewhat common, but it's not normal, and it's highly treatable. And all of the 6 medicines that you talk about and the 4 M's, that's how we treat, that's part of how we treat it and how we're paying attention to depression and preventing it. The other myth is that if someone is determined to die, nothing can stop them. But we need to remember many suicides are preventable. And we do that by recognizing the warning signs, by just having a high level of awareness about the possibility in older people, especially older men, and seeking for ways to connect and have these honest conversations. And the final myth, which I hear all the time, that talking about suicide might put the idea in someone's head. And I get asked that a lot, like, why would we ever ask that? Because my father wouldn't have even thought about suicide if we hadn't asked the question. But it's actually not true. Talking about suicide and asking about it is really one of the only ways we can confront the isolation and the ideas and thoughts that someone might be having. And if we fail to talk about it, we're not giving them access to some of the support that we could provide. And so someone who has never considered suicide and isn't likely to go that way is not going to be pushed to suicide because we ask them about it. So don't hesitate to bring it up and talk about it in a situation where it seems like it may be important. And then next slide. So 3 takeaways. Suicidal thoughts are often temporary, and you might be showing up when a person is having a moment of despair, but if you can be there for them, help them connect at that moment, you can move them out of the danger zone. And so it's always worthwhile to take the time to ask about it and listen to them. Listening may be the most powerful intervention because all of us need to feel seen and heard. And just having someone who's willing to sit down and give you an extra bit of their time during the day to hear what you need to talk about, that could be one of the most powerful types of medicine there is. But ultimately, you're not responsible for another person's final choice. We are here to care about people, to notice the situations that they're in, to connect with them ourselves and connect them to help. But ultimately, the responsibility for their choices will lie in that person's hand. That was a lesson I learned the hard way with my own father. And so finally, in the next slide, I just wanted to say, I offer this to you because having been on a journey with my own father through his progression towards suicide and doing everything possible to try to help him, including getting mental health help and showing up for him and being there for him. Um, Sometimes, even when we've done everything right, someone may still die by suicide. And as a psychiatrist friend of mine said, at times, suicide is like a trap door that opens for a person and they fall through it in the moment. And no matter how hard we've tried to remove all the trap doors or prevent them, it it can still happen. And I say this for anyone who does this work and listens to what I've said and goes out and wants to help another person. Um, it's still possible. Some people may still die by suicide, and I want to encourage you to have compassion and offer grace to yourself for the work that you do, and know um, that we do our very best. We show up for people as much as we possibly can, but we may not be able to prevent all the trap doors that open for someone to fall through. And so I guess before we go to the cases, I wanted to see if anyone has questions that you'd like to ask right now.
Yeah. So thank you, Dr. Wyatt, for that very thoughtful and compassionate presentation. And we did want to let everybody know that we had just a little mishap with the timing on iEcho, and we wanted to let you know that, as stated in the chat, we will make sure that we get the recording to you so that you can experience the whole thing if you came in late. So questions or comments, things that have resonated with you? I want to say thank you for sharing your experience with your father with us, and just appreciate all of these resources that we can return to as we think about how to utilize these resources and frameworks with the work with our patients and our clients as we move forward. And I wasn't aware of the Institute on Aging Friendship Line that was 24/7. So that's helpful as well. Let me see if there's anything in the chat. We have some of our Project Echo community members saying, thank you, was a wonderful presentation and good information.
Karen, I have a question.
Yeah.
So, and I experienced this very recently. There's somebody that I know that's an acquaintance, and I've known them as an acquaintance for years, and they made a post on social media. And basically the post was, what's the least painful way to die?
Hmm.
And I was horrified at the number of responses that were quite callous. And there were several people that chimed in, hey, call 988. Do you have a therapist? Can you call me? But I would say that they were way in the minority.
Hmm.
And I reached out to the people that had made what I consider the more pro-social comments and thanked them, and then followed up with the person to say, hey, have you been able to reach out to so and so? They have some really great suggestions. But it's like, do you think that that is a way to start to engage and change public narrative around this? Because I could see that a lot of people were just like, it's not that bad. Like they literally said something like that. So is that, because I think part of this is changing the public narrative. And do you think that that's a way to do it, is to nudge conversations like that, especially in a social media platform, in that direction?
I think, well, social media is tricky just because sometimes we have bad actors and bots that say cruel things intentionally, but I think we have to pay attention to it because it is one of our modes of communication now, that people use to put messages out. And so I think we do have to look at that. Is that a cry for help? Is it someone asking for information? And I do think if we see that kind of post and we could make a positive comment or a helpful comment, I think that's really important. But it's an interesting question for someone to ask, and it does make you wonder, why are you asking that, and what's going on. But it also shows me in our society in general, we don't have enough conversations about death and dying and the end of life and what that looks like, that we do need more of all of these conversations. And so I think it's almost always helpful to foster healthy communication. I worry that social media opens the door for a lot of unhealthy responses too, like you were seeing. But
And we have a question in the chat from Tanaya. Tanaya, would you like to come on and ask your question? So Tanaya says, so how do you go about the situation if someone doesn't want help?
I think that would be one of the cases. I mean, you can go so far as to, you know, call law enforcement, take them to an ER, get them admitted to a psychiatric facility for their own safety, which is pretty drastic if that would happen. Um, I guess what I would do is continue the conversation and see if there's someone else close to them that I could engage who could come and sit with them or be with them. As a provider, though, for me, a medical provider, there's an obligation to connect people with services and to do whatever we can to prevent harm from being done. So it's possible that you'd have to take matters into take away that person's control temporarily to seek help for them, um, by getting them forcing them into a facility for some kind of care.
Mhm. Let's see. And then Misty shared in the chat, great presentation. This really hits home as I've experienced this a few weeks ago with a resident of mine. And there were no signs and was a happy person.
It's just so good for us to talk about it and think it through so that we don't feel so blindsided if it comes up when we're with someone and we feel a little bit of panic because if we've never faced the situation before or thought it through, it's really hard to know what to do or say in the moment. So it's really this is really healthy that we're all here talking about it right now.
Mhm. And then Susan wrote in the chat, just 2 months ago, a friend of mine found her elder mother dead by suicide. I think it's more common than we think.
Yeah. And if you think about it, there may be deaths that don't get ruled to be suicide, but that, some like accidents
Mm,
that happen that could have a suicidal intent behind it, but we don't know for sure. So they don't get labeled as that too. But I think you're exactly right. I think it's still somewhat hidden in our society. In fact, even for me, when my father died by suicide, I could not talk about it with my friends. I couldn't tell my colleagues or friends or talk about it for a few years because it was so stigmatized. I felt like I just cannot have an honest conversation about this.
yeah. I wondered how much about that because I think about how it is in some religious traditions, it's a sin. And so years and years and years ago, that's the way it was referred to. So it just put that stigma up and
Yeah. Yeah. And I felt like I needed to protect my father from other people's judgment. That's what I feared is that my father was a complex, amazing, wonderful person, but having people, if the only thing they knew about him is he died by suicide, they would form judgments in their mind that have nothing to do with him. And I just couldn't bear for that to happen. I couldn't somehow expose my father to other people's judgments when already he had been struggling with
yeah.
a lot of pain. And so in my mind, that's why I had to keep it silent for a long time till I realized, but that doesn't serve anything. It's so much better if we talk about it.
Mm. I'm wondering if we could turn to one of your cases.
Yeah. I brought these real cases from my practice, both in a family medicine doctor and a hospice doctor. So one from each of those settings. And this was a 69-year-old male patient. I was seeing him in the clinic just for a regular checkup for hypertension. As I was literally, my hand was on the doorknob to leave the door, saying goodbye to him, he said, "I don't want to be here anymore." And oftentimes that's how the topic comes up. It's when you're ready to leave. You've already spent like 15 or 20 minutes having a great conversation with someone. They don't tell you what they really wanted to say until the moment you're ready to leave. That's when they finally have the courage to speak up. And what that requires then is, uh-oh, now my schedule is going to be off because I can't just walk out the door and leave when this person has asked for help at this moment. So our commitment ends up being, all right, I'm going to sacrifice a bit my schedule today and the other people waiting for me because I need to pay attention to this right now. Um, and so if anyone wants to talk about what would you do, what would you say in that moment or what, I'm not sure how your case studies go, but I assume other people chime in here.
Correct. Yes. Yeah. So what would individuals do in this particular situation? Any thoughts?
I would say probably try to get down to like the problem as to why he doesn't want to be there anymore, or try to just like like you said, give a listening ear just to make him feel comfortable and make sure he doesn't feel that way once you guys leave each other.
And that's perfect because that's the first of the five things we can do, which is just asking a question and ask further for more information. And in this case, the patient said he was having suicidal thoughts. He didn't see a reason. He felt like he was at the end of everything in his life. He'd finished everything. He didn't see any reason to still be here, and had been entertaining thoughts of, what if I end it now? What if I end my life? And so I don't know if anyone has any other thoughts about what would you do next hearing that.
I think it's also important to ask them if they have a plan or if they're looking to act on it. I mean, I think there's a lot of times when people get down, and not trying to say that suicidal thoughts are normal, but it's really good to kind of dig in a little bit more and thank them for talking to you and see if they have an actual plan in place.
Exactly, exactly as on the list of things. This man did not have a plan and did not have lethal means available to him, firearms or something lethal in the moment that he might have used impulsively. But so he was kind of at an earlier stage of considering, do I want to be here, and how might I end my life, and why? Um, I'll just disclose what actually happened with this man. He's the same age my father was when my father died of suicide, 69. And he came in my office 3 months after my father's death, when I was still in the middle of grieving. When he told me that he was thinking of ending his life, I got emotional, which it's not professional, but it is grief. It is how grief behaves. And I got emotional. I stepped out. I said, I need to step out for a minute so I could compose myself and come back. And when I came back in the room, he said, maybe I shouldn't have said that. I'm sorry. What happened? What happened right now? And I ended up disclosing to him that I'm grieving. My father died by suicide just a few months ago. And he was stunned. And at first, I just thought, oh my gosh, I just violated all of the rules, everything. I'm not supposed to tell anyone about my personal life. It's not about me. I shouldn't have brought that up. But what he said to me is, I never thought about the impact something like that would have on my family. That never occurred to me. And he said, thank you for just being honest with me, because now I'm thinking about it differently. If I made that choice, it would cause so much harm. And he continued to be my patient. I saw him many times for several years after that. Several other times he said, thank you, because you turned my thinking around when you told me your experience. So I learned then there is a time and place sometimes when we need to disclose things, because that experience of mine was powerful and life changing and had the ability to help to change someone else and their thinking about it. That's how this case ended up turning around. And so, but the very first thing we do have to ask is, are you thinking about suicide? Do you have a plan? Do you have the means in order to get to the place where we know if we need to act further or not?
I think we have time to do the second case.
Okay, and I can just quickly present this, but this was in hospice now, a man who's terminally ill, had terminal cancer, 81 years old, a prognosis of 6 months that when he got admitted, but no one knows for sure in hospice how long he might live. But he said repeatedly when we first admitted him, I would rather die today than go through any of this. It set off a big ethical discussion in our hospice, because he's serious. He would rather die right now. But we lived in a state where medical aid in dying wasn't legal. That wasn't something we could refer him to or help him with legally. And he had pain medication in his home because he had pain from cancer. The big question was, some people on our staff thought we should confiscate the pain meds so he doesn't have the means of overdosing. And yet, what harm would that do to this man whose biggest fear was being in pain, was that he would die in pain? How much would that harm him if we said we're controlling your medication so much that we're keeping it out of your hands? It felt to us like that would precipitate his desire to not be here if he couldn't have control over pain. I'm sorry, I'm just saying all of it is letting you talk and ask questions, but I just wanted to present the ethical dilemma that arose because some people felt, let him have all the meds he wants and let him take it if he wants to. He has the right to end his life. Others wanted to protect him from that. I don't know if anyone has a comment to make on that situation.
I'll say that when I first started volunteering as doing hospice volunteering, I was I realize there's different layers of acculturation and different layers of training, but it's like the first time a patient tells you they want to die and they're in hospice care, it can be like really startling. But over time, you start to kind of get not used to it, that's not the right word, but you start to kind of go, oh, okay, this is where I should ask more questions. And a lot of it was in the phrasing. And so as I've listened to other hospice providers, like you start to kind of discern and you kind of use good questions to follow up to ask what they mean by that. And a lot of times you realize, oh, they mean something very different than I have an actionable plan and intention. And so I just want to say that like that was a real wake up call for me. And did you feel that in your hospice that that was something that it's like it takes a while to discern?
Yes, because I think in all of my training was how do we help support someone who's, on this slower path toward death and willing to be there. I mean, how do we keep them comfortable? How do we treat their symptoms? And I didn't have any training that said, what about the person who says, I'm going to take all these pills today because I don't want to go through any of what you're offering me here. We were offering him all kinds of support. And he's saying, I'd rather take all the medicine right now and put an end to it. Um, and so there was a little bit of inadequate training on our part as to, well, that's part of the spectrum of how people might react with a terminal illness, but we didn't feel quite prepared. When this gentleman talked with us, we did discover through listening to his stories, though, that he was a veteran. And one of his issues was he felt like he didn't quite belong, like there was no one he could talk to. He really wanted to process some of his feelings and experiences about being a veteran, but there was no one in his life who really understood what that was like. And we were able to connect him. We had a volunteer for our hospice who was a veteran himself, who started coming to visit him a couple of times a week. So he had a comrade, someone who knew what is it like to be a veteran and to do military service. And that was a missing piece for him that needed to be connected. Um, but it's an important issue to think through. And hospice still grapples with this, even where medical aid in dying is legal by law. Some hospices don't want to assist people who make the decision that they want to choose when and how they die instead of just letting it unfold and take a natural course. And it's an ethical dilemma for all of us to think about.
And Christine has a question in the chat. In that kind of situation, could you have somebody administer their medications or somebody that could monitor that? Is that
If there's a family member who's able to do it, it puts the family member, their caregiver, in a little bit of a position to hold all of that responsibility. Like, now you have to keep these under lock and key, and you have to control the meds this person receives. It is possible to arrange that, but sometimes we make things a little bit worse for the patient. Like I was saying, if we indicate that if we're controlling things a little too much and the patient feels like, but now who will believe me if I tell them I'm having more pain, and will I be able to increase my meds when I need to if you've taken that away from me? So, but that is possible. We have done that with patients before. Some patients are not uh, able to manage their meds anyway. Like that's some patients have to have other people in charge of their meds.
I was just going to say really quick, I think it can also work to who's in the room, kind of what you were saying, based on what the family is saying. I saw an incident where the wife couldn't handle what the husband was going through, and she just wanted, not in a, I don't mean that in a non-compassionate way, but she wanted to kind of hurry things along. He was no longer verbal. He was no longer, so she felt ending it for him would be more of a place of compassion. And that, luckily, I was not involved in that in a professional capacity. But yeah, it was, you could see that it heightened her distress, heightened the patient's distress, which then heightened everybody else's distress. So
Yes,
she
these
felt
are
like she was doing the most compassionate thing, but obviously that was not how everybody else felt.
yeah, these are very real situations and tricky and important that we be able to talk it through. But it's a gray area in a sense that it, it's it's not always clear. I guess it's individualized in every case. It's not always clear how to direct people.
Can I ask a question? A similar case, but not identical.
Yes, yeah.
So just in terms of discerning suicidality versus just accepting that you're in it life at end of life. And I knew, mid 80s-year-old woman, her husband died. They had literally known one another since kindergarten. She did not know a life without him. And she immediately upon his death started giving everything away and saying, well, I'm ready to go. God can have me now. She also struggled her entire life with substance use because of chronic pain. So she had a lot of access. And, the question kept coming up of like, oh, should we take her meds? And I don't know honestly whether or not anybody monitored that for her, though she was in various different assisted living or living with family members, but she ended up outliving him by 12 years.
Hmm.
And for like the first 5 years after his death, she's like, I'm ready to go. I got nothing to do here. And so she wasn't actually suicidal from what I could tell, though her behaviors were, here, have my things, I'm ready to go, don't know why I'm here. But she was okay. And so I'm just curious, like how you would discern that?
It does make sense to me that some people, part of their acceptance of growing older and of growing nearer to the end of life might be in a way letting go of some of their attachment to life, like they're letting go of their possessions and attachment to that. And they might be just saying, um, I'm willing to go now. If I die tomorrow, that's fine. I'm willing to. And that's very different than saying, I refuse to be here. I can't stand this and I don't want to stay here. So I think you're right. We do need to just keep listening and asking questions to try to understand what they mean when they're talking about that. Because I could imagine that. I could imagine being at a place where, hey, my attachments are gone and I'm willing for it to happen whenever it does. My own mother, that was her attitude, and she lived for 5 years after saying that, like, I'm ready to go anytime, anytime. And each day she'd call me, I'm still here. I'm here today. I just wanted to let you know.
Okay. We have one more comment, and I'm going to see if Rita would like to come on and share her comment.
Can you hear me?
Yes.
Uh, when y'all was talking there and you was talking about my dad's in hospice. He is 81 years old as well. He's bedfast. Uh, we worried about him committing suicide because he always wanted a gun or a knife or some other object that he could use. So we would always keep those hid. But he can't get out of the bed, and it's a hard decision to decide what pain meds to give, what keep his depression medicine going, because he don't want to be in that shape. And I can see his place because he's bedfast. You lay there, you have to depend on everybody to bring your food, to change your clothes, to change your catheter, change your diaper. I can see his point, but it's very hard to let go. And I don't want him, I want him to die natural. I don't want to send him to the care center because I know what happens and it scares me. And it's just a big decision. It's hard on my mom, it's hard on everybody. So, it's hard when you get in this situation and you have to deal with this.
It's very hard because we don't want to see someone we love suffering, and we don't want it to be prolonged if for no good reason. And so I fully understand that you have compassion for why he wishes that things would speed up and that it could just happen sooner. And that is something in hospice care that we grapple with a lot, but also talk about a lot with people and families. How do we keep alleviating the symptoms the person has and help them stay comfortable? And particularly when we don't know how much longer it's going to be, and we can't say that to them, it'll only be a few more weeks. We don't know that. I think that uncertainty is also really hard to live with.
And I try not to give advice to too many things because I have learned you never know what you will do until you put those shoes on.
That's very true. That's very true.
I think that is going to end this part of our Project Echo. Thank you so much for coming here and sharing your presentation with us and having us ponder and consider and think through how we would react in various situations, and providing us with all these resources. And for those individuals who had to join late, we do have the recording for you. And we just thank you for bringing all of the guidance and wisdom to us in our Project Echo community. And thank you, everyone, for sharing your personal struggles in your own life to get us to think through those things. All right, I think I'm going to pass the mic to Justin, who's going to share the rest of our Project Echo announcements.
Thank you, Pam. And just a reminder that today's session is recorded. So if you got here late, I do apologize for the time communication piece through iEcho. We became aware of it thanks to Dr. Wyatt about 10 minutes before we were joining. So I didn't have time to fix it. But you can find the recording. If you go into iEcho and click on today's session notes, you'll see something that looks like this. There will be a PowerPoint that will have all of the references that Dr. Wyatt shared, as well as events and things like that are shared during KCHC, and the session recording will be under today's session notes, so you can access that later on this afternoon. This is the Kentucky Coalition for Healthy Communities. Welcome. Just a few reminders about what we aim to do. We work to train and empower stakeholders and community members to provide hope and education in your communities. And so we really are inviting people to come from local coalitions, and we'll have opportunities for you to share events. We'll have opportunities to really share how we're going to take this information back into our communities. So what's something that stood out to you today, and how will you share this with your community? So you can either unmute or put it in the chat, but I'd love to hear how people plan to take this information forward and share it.
Well, I'll say one thing I learned today from this presentation is that men are most likely to commit the suicide than women. That's one thing I definitely did not know. How will I share this information? Probably just have like a conversation with a couple people I know, just to let them know the information I learned today so they can share that information as well.
Yeah, thank you, Tanaya. Anybody else have ideas how you'd take this information back into your communities or the people you serve?
I'll be sharing it with my students, social work students, and specifically the social work and aging students.
Okay, yeah. Thank you, Susan.
I really appreciate the specificity in terms of how to help somebody who's struggling with suicidality to connect. Because I honestly, I've had another training recently about suicide prevention. There's some material that was similar, but I really like the specificity of this workshop because I think just that making a list of who can you contact or who can I contact for you, that seems much more tangibly actionable than like, here's a suicide line to call because I don't think everyone relates to contacting a stranger. Some people prefer it, but I think others, especially people that I know personally, would relate more to that. Let's list who are the people you can call. So I really like and appreciated that portion.
Yeah, thank you. And Christine chimed in the chat that they'll utilize it as a mental health provider of chronic illness. I definitely, think that this information is timely and can be used by all of us. Anybody else have ideas of how you might take it back to your communities or the people you serve? Yeah, Destiny. Yeah, thank you. Yeah, asking directly and then screening for suicide. Yeah, I think that's really, really important. And I think that for me, that's being able to that ask direct piece is something that is going to be a learned skill, I think, but also, feeling that there is support, kind of what Justine was just saying, that we can, point to resources that are available. Yeah, that loneliness piece, Chandler, of being equivalent to 15 cigarettes a day. When I hear that, I'm always like, how would we quantify that? But I can see it and I can hear it when I listen to people talk about the effects of loneliness. Yeah, it definitely has effects. So Vicky, great question. So later on today, if you log back into iEcho where you joined today's meeting, you will be able to find all this information in the notes for today's session. So I'll have a link for the recording and a link for the PowerPoint. Okay, so anything going on in your communities you'd like to share? Susan, yeah, so the CEU, the continuing education, there will be a link at the very, very end of the session that I'll share. So any events going on in your communities you'd like to share? I want to remind people that National Healthcare Decisions Day is on April 16th. And so just a plug that every year, the day after tax day is the day to talk about end of life wishes and advanced care planning. So that's coming up on April 16th. And the Traeger Institute's Optimal Aging Conference is going to be April 16th and 17th. So if you would like more information about either of those, you can always reach out to me. Anybody else have events you'd like to share? Okay, so just a few reminders of things that we have coming up. We have My Health Matters on Monday evenings from 6:30 to 7:30. You can join through Zoom. You're always welcome. You're always welcome to share this with anybody who might be interested. We have some great topics coming up. Actually, looking at anticipatory grief on April 6th, which is a relevant topic, but also some great topics on healthy eating, understanding osteoporosis, and a variety of topics that are relevant to older adults and people who care for older adults. So if you ever have any questions, please reach out to Mona. And again, this will be in the PowerPoint that I share a little later. We have our diabetes self-management program Thursdays starting April 6th through May 28th from 6 to 8:30. If you have interest or you know somebody who would be interested in benefit from this, you can complete the diabetes self-management program interest survey. And again, all of this information will be in the PowerPoint that I share through iEcho. We'll have a Flourishing Together program that'll start soon. And you can always reach out to Mona to ask for more information about that. And we'll be updating you on future dates, probably at our next session in April. A couple other programs, we have our Flourish program, we have Caregiver program, our Virtual Friendly Visitors, and then our Pearls program. So if you ever have any interest in any of this, you can always reach out to myself or Mona, and we will connect you to the appropriate person to get you more information. If you are interested in learning more about caring for older adults, we have our Optimal Aging Scholars program. Attending a Project ECHO is one of the requirements, but we really try to give you an interprofessional view of caring for older adults. So you would complete some online modules, attend an interprofessional case management experience, participate in our Impact 4M training, which really takes a deep dive into age-friendly healthcare principles, and then participate in our annual Optimal Aging Conference. And so if you're ever interested in this, you can reach out to Sophia or myself, and we'll get you more information. So really, we're working statewide to try and take a lot of the information we're doing out into the community. Our Flourish Care Centers of Excellence are doing this in the KIPTA area, the Cumberland Valley area, and the Barren River Area Development District. Working through our AAAs, we're really working to build a community outreach and education platform to really help strengthen transitions of care and really infuse age-friendly healthcare concepts out in our communities. Again, you can always contact me or look at the PowerPoint and you'll be able to contact the coordinators for those different regions. And then just really always encouraging everyone to remember that we're really working to become a state coalition to work with community members and community-based organizations to empower our state to become a healthier and more compassionate people. If you look at the state rankings for Kentucky, we have a lot of work to do, and I appreciate everyone being here and hope you take this back to your individual communities so we can practice self-care and model healthy behaviors for our families, coworkers, and members of our community. And so this is our upcoming schedule. I want you to note that in April, we're meeting on April 24th instead of the 17th because the 17th is when the conference is. And then here's our schedule for the rest of this session. Hope to see you at a future session. Remember, I'm going to review everything twice, but our sessions are always 12 to 1:30 Eastern time. And I will make sure that we iron out quirks with the scheduling. So I apologize for anybody that came in late today. And this is our session evaluation. I am going to stop sharing just for a second so I can put the link in the chat. So give me just a second, I'll pull that back up. But I really want to thank Dr. Karen Wyatt for being here today. It's lovely to stay connected with her work. And if you would ever like to learn more, there's going to be contact information in the PowerPoint. But I put the session link for the evaluation in the chats, and you can use the QR code as well. But I am going to